So Dr. Darrell Gray is an associate professor of medicine in the Division of Gastroenterology, Hepatology, and Nutrition at the Ohio State University College of Medicine. Additionally, he serves as the deputy director of the Center for Cancer Health Equity, Comprehensive Cancer Center, as well as the medical director of the Healthy Communities for OSU's Wexner Medical Center, and is also the chair of the OSU WMC Health Equity Steering Committee. He received his medical degree from the Howard University College of Medicine and completed his residency at Duke, GI fellowship at Washington University, and public health training at the Harvard's Chan School of Public Health. His work leverages meaningful partnerships across public and private sectors to address health disparities and upstream social determinants of health amongst diverse populations across the state of Ohio, as well as nationally. Most recently, he co-developed the Anti-Racism Action Plan for the Ohio State University's Wexner Medical Center and the Health Sciences Colleges. His work has been well recognized and has received numerous honors, including induction into the 2017 class of National Minority Quality Forum 40 Under 40 Leaders in Health, the Helio Disruptive Innovator Health Equity Award, a National Colorectal Cancer Roundtable National Achievement Award, and multiple ACG Scopie Awards, to name a few. So he's a very well sought after speaker regarding disparities in health, and we are fortunate that he's joining us today to talk to us on bringing the moral determinants of health to the bench, bedside, and community. Thanks so much for joining us, Dr. Gray.
Thank you so much for that kind introduction. It's truly an honor to be amongst you, and thank you for the kind invitation to be here. It's really nice to also be amongst family. So thank you, Drs. Greenwald, Itzkowitz, Pascal White, Ugo Oruku, and many others who are there. It's really an honor to be with you today. It was nice to also tune in to the presentation at the latter end of the presentation to, for a second, get PTSD of doing, in regards to doing liver biopsies blind as a first-year fellow at WashU. So thanks for that PTSD. Let's dig right in here. For a second, if you'll just indulge me, if you're not driving, if you're not doing a scope while listening, I want you to close your eyes for a second. And as you close your eyes, I want you to just reflect on, if you're a trainee, your work as a trainee, if you're faculty, your work over the years, and just think about a time when you actively contributed to reducing a disparity. Certainly that could be an IBD, liver disease, advanced endoscopy, a transplant, liver transplant, general GI, you know, the list goes on. But think of a time when you actively contributed to reducing a disparity. And also think of a time when you missed the opportunity. Okay, open your eyes for a second. We're gonna have some fun today. I do not have any financial disclosures, but I should disclose a few things that really inform the work that I do and inform what I'm going to be sharing with you today. I am a man of faith. I'm a father and husband of close to 11 years, 3 kids, physician, and also a community advocate. My practice does take me into the community, obviously in the clinic, in the hospital, but my research practice also takes me, I do quite a bit of community-based participatory research. And what I hope that we achieve today is hopefully you get a lens into really 2 things. I have a third objective that is not listed. It's more of an informal objective. And that third objective is that there is at least one thing that you can take from what we discussed today, how we engage with each other, and implement that into your practice, whether it's what you do in your workplace or the community, or even at home and amidst kind of your social networks. It's March. It's no longer Black History Month, but it's always a good time to share a Martin Luther King Jr. quote. He said, "We are now faced with the fact that tomorrow is today. We're confronted with the fierce urgency of now. This is no time for apathy or complacency. This is a time for vigorous and positive action." And certainly as we look across the landscape, I'm demonstrating life expectancy here. As you can appreciate, from the 1970s to present day, what's illustrated is only to 2016, but you can appreciate that disparities have persisted over time. Now, certainly our life expectancy has increased over time. But what I hope you also appreciate is that there's significant gaps based on race and gender. And a lot of times we look at these graphs and charts like this, and it's hard to put faces with it. We become blind almost to that these are actual people that these numbers are representing. So if you wouldn't mind, please indulge me as I share some pictures. At the top, we have a beautiful a white baby girl. The second picture was my daughter, my oldest daughter, who's now 6, and she was very young. The third picture is a very handsome white baby boy. And the fourth picture is my son about a year ago. And what you can appreciate as we look at this, we put it in context of our children, of our family members. You can appreciate it's quite disturbing that there's a 10-year life expectancy difference. Again, that can be based on gender and race. And certainly, as we look at the first half of 2020, we reflect on that. Really, we saw a drop in life expectancy, and a drop more precipitous than we've ever seen, or that we've seen, excuse me, since about 2006. And that disparity is most prevalent amongst non-Hispanic Black males. And certainly, as we think about ourselves as a nation, as a healthcare landscape, we really aren't necessarily getting the return on what we were investing in healthcare. Well, how is that manifested? Well, certainly as we compare ourselves to other economically developed and wealthy nations, we see that we have lower life expectancy, higher obesity rates, chronic disease rates, suicide rates, avoidable deaths, and yes, hospitalizations from preventable causes. Now, some of you have not ever been to Ohio where I am now. I'm in Central Ohio in Columbus, the capital. And what you can appreciate about Ohio, unfortunately, we are poorer, less educated, less racial and ethnically diverse than most of the nation. But we do have some special populations that contribute to our diversity, and that is our Appalachian population, which is geographically, if you will, somewhat isolated population along the eastern and southern parts of Ohio. It's 32 county area that is a healthcare professional shortage area, a predominantly very poor white population. We also have a large new American population. We have the second largest Somali population in the United States to Minnesota, and we also have a large sexual and gender minority population. But let me take you closer to where I live personally. So my office is housed in Franklin County. My clinical practice is right in Columbus, near the Hilltop area. What you can appreciate if we zoom in there's actually, if you just go a couple of counties over, you'll notice greater than a 25-year life expectancy between Franklin County and Hamilton County. Okay, but even if I go literally just a couple of streets over into a different zip code, I recognize that the life expectancy can be similarly 20 years different if I just drive a couple of streets. Now, this is not foreign to you, because if we look at New York, I also know that if we just go 6 train stops away, we know that a baby born can have a 9-year life expectancy difference in East Harlem than they do in Murray Hill. But I'm also a gastroenterologist, right? And it's also Colorectal Cancer Awareness Month, so I cannot help myself. Let's zoom in for a second through the lens of colorectal cancer. Certainly, we all appreciate that colorectal cancer and the burden therein is not equitably distributed, right? This is no foreign graph to you or chart to you. You'll appreciate that there is a greater burden of disease if we talk about incidence and mortality amongst non-Hispanic Blacks as we compare to whites. But again, you also know and appreciate this is not just about race. It can be impacted by geography. So certainly I highlighted Ohio previously, and I'll highlight it again. You'll see that in the southern tip of Ohio, we're one of the kind of hot spots of colorectal cancer in our Appalachian region, where you have some of the highest rates of colorectal cancer as compared to other regions. But you'll see other areas where it's red is bad, red is where you don't want to be, where the incidence, or particularly in this graph, the mortality is highest. But again, so we talked about race, we talked about geography. We also have to appreciate educational attainment. This is not new, but if you look at this chart here, that's divided by kind of tertiles, years of education on the x-axis and deaths per 100,000 persons from colorectal cancer on the y-axis, let's focus in the center. So if you look at non-Hispanic Black population, I insert myself into this graph as a Black male who's had greater than 16 years of education. You'll appreciate that my likelihood of dying from colorectal cancer is higher than a Hispanic individual with less than 12 years of education. But also, if we look over to the left in non-Hispanic whites, you'll see it's greater than those with similar education or less than as well. But also, as we think about socioeconomic status or insurance status as a surrogate for socioeconomic status, we see that as we look at every stage of colorectal cancer from stage 1 to stage 4, and we look at insurance from private insurance marked in the red with the X, no insurance marked in the green, and Medicaid, which can also be a surrogate for poverty, similar to no insurance, is marked in the yellow. What you can appreciate is colorectal cancer survival is lower for patients with no insurance or Medicaid as compared to those with private insurance. But so that's colorectal cancer, but let's zoom out now to where we are today, the tale of two pandemics, if you will. And we see the urgency of now amidst this. Certainly COVID-19, we've learned since March 2020, that as we gain data, people who are disproportionately dying, people who are disproportionately developing cases of COVID-19, and people who are disproportionately represented amongst the hospitalizations are those Black and Indigenous people of color, all right? But we also know that these are the same populations that have been disproportionately affected by systemic inequity. And certainly, many of that, there's been a clarion call, if you will, since around June of 2020 with the death of George Floyd, right? And many people saw that 8 minutes and 46 seconds televised, but trust that there were many more 8 minutes and 46 seconds that have occurred over decades and, may I say, centuries. But again, let's take a look, magnifying glass to 2020. And certainly as we think about whether it's colorectal cancer deaths, we think about COVID-19 deaths, certainly as we look back to March 2020, what we started to see is that, yes, COVID-19 deaths, as I showed on the previous slide, were most prevalent amongst Black and Indigenous communities of color. But the narrative that was coming out, well, these are the same populations that have higher burden of colorectal cancer, higher burden of heart disease, diabetes, mental health issues, obesity, asthma, and many other chronic conditions. But the question that we didn't raise, and the thing that we didn't necessarily take a magnifying glass to, is why is this, right? These are symptoms of underlying problems. What are the root causes? And certainly if we look further upstream, we see that there are determinants of health, whether it be food insecurity, so living in an area where you don't have access to fresh fruits and vegetables, whether you're in a food desert or a food swamp. A swamp might be something where you have more McDonald's, more liquor stores than you have actual fresh fruit and produce stores or grocery stores. Maybe it's unsafe and overcrowded housing, because certainly many of our essential workers, whether they were bus drivers, taxi drivers, driving the subway, working at grocery stores, they weren't necessarily able to safely distance from one another, but also as that workforce is usually underpaid or they don't necessarily have a good living wage, they also lived in unsafe and overcrowded housing where they couldn't even distance from family members who contracted COVID-19, right? These people are also more likely to live in areas that with high exposure to toxins and pollution. But also as we think about what happened in March, right? We had a revolution in telehealth, right? We switched because we didn't know how to approach patient care, in-person patient care. So our health systems rushed to deploy telehealth in a way that we haven't done before. But what were we doing? We're allowing people to fall through the cracks because why? There were people in some areas who didn't have access to Wi-Fi, or they had access to Wi-Fi, but they didn't have the devices to use to have a telehealth encounter. Or maybe they had the devices, but just did not know how to use it to access your portal to have a telehealth visit. Okay, so we can see how that impacts downstream outcomes, but we must look further upstream because these things are all results of poverty, racism, and yes, discrimination. Now, I'll put a pin in there for a second because inevitably I get questions. Well, Doc, don't you think that wealth is protective from racism and discrimination? Don't you think your education is protective against racism and discrimination? I submit to you Exhibit A. Unfortunately, we had Dr. Susan Moore. Many of you may be familiar. Her case was widely televised. She actually put it on Facebook, and it was publicized thereafter, where here was a doctor, someone of high educational attainment, someone of socioeconomic means, who was hospitalized with COVID-19 at a hospital in the Midwest. And she said, and I quote, "I put forth and maintain if I was white, I would not be treated like this." She was discharged and ultimately died from complications of COVID-19. So a lot of what I'm talking about is in regards to the social determinants of health, the conditions in which we live, work, age, born, thrive, and inequities in power and resources that influence those things. Now, many of you might know that, what we do from day to day in the walls of our clinic or our hospitals, what we do with healthcare is only responsible for a minority of someone's health and well-being. Studies quote between 10 and 20%. The majority is from these other factors that contribute to someone's health. And so if I take you back to Franklin County where I am, I'm going to show you a few things. So in the blue, you'll appreciate these are the census tracts in Franklin County where four or more health conditions are at their worst. So we're talking about things like heart disease, diabetes, chronic kidney disease are at their worst. Okay, keep an eye on those blue areas. You'll appreciate in these same areas, and this is no different if we look at New York, if we look at other states and other areas and other counties, boroughs, these same areas have low opportunity, whether it's in regards to resilience of the community or low economic opportunity. Same thing for health opportunity, and same thing according to the CDC's Social Vulnerability Index, right? And that takes me to another theme, and that is the policies and politics that influence health. Some of you may have read this book by Daniel Dawes that was published in 2020. If you haven't, I highly recommend it. And it's called The Political Determinants of Health. In the beginning of the book, he paints a beautiful allegory of a farmer. This farmer wants to start an orchard. So he's looking for land. He stumbles upon this beautiful tree that's blossoming fruit, but it's not what he wanted to plant. And so he displaces this beautifully blossoming tree with fruit. He puts it on a far end of the land in an area where there is nutrient poor soil. And he plants his own seeds in this area where the nutrient rich soil is. He plants some seeds where there's kind of nutrient more poor soil, and then plants some seeds in some very rocky soil. To cut to the chase, what he notices is that he certainly invested his time, his money, his resources in this area where he planted the seeds, where he wanted to see his crop grow. And what he noticed when it was time for harvest, that none of these trees actually blossomed well, right? So I submit to you that, certainly as we think about our work and impacting the lives of those who have been made vulnerable by systemic inequity, we think about those who are very privileged. We all as a society cannot thrive together unless we all grow and we all contribute resources to those who need it most. Because in the end, we won't also be healthy. And that was the same thing with these trees. They all could not realize their full potential because they were interconnected. Even that tree that had the fertilizer, that was watered well, that was tended to, could not thrive because it's interconnected with those that were not. And so as we think about things like residential segregation, going back to social determinants of health that I showed you in the previous slide, and their impacts on health outcomes, it is incumbent upon us to think about how this impacts our patients' lives and what we can do to influence it. And I'm going to take you to my home. I'm originally from Baltimore, Maryland, and you can see this manifested there. So in the red on the left, you can see Baltimore. The red areas show areas of high redlining. Redlining basically refers to where people were segregated as a result of policies that were put in place in regards to lending and mortgage practices. And so you see in those same areas that were high as far as historic redlining, those are the same areas where the life expectancy is lowest. So these things are interlinked: social determinants of health, political determinants of health. Some of you are listening. You're saying, well, Doc, I'm an IBDologist. I'm an advanced endoscopist. I'm a transplant hepatologist. I'm a gastroenterologist with expertise in inflammatory and irritable bowel syndrome. Is this my lane? Let's take an examination for a second for someone who believes that it's not their lane. This was a commentary that was published pre-pandemic, September 2019. It's called Take Two Aspirin and Call Me by My Pronouns. And a little bit of pandering here, as you can see, at woke medical schools, this author says, curricula are increasingly focused on social justice rather than treating illness. And it goes on to say, why have medical schools become a target for inculcating social policy when the stated purpose of medical education since Hippocrates has been to develop individuals who know how to cure patients? And it goes on, even amidst the pandemic, to publish another one that says med school needs an overhaul. Doctors should learn to fight pandemics, not injustice. Goes on to say, above all, that physicians can be trained to solve the problems of poverty, insecurity, and racism. Patients should abandon the fantasy, that physicians can be trained to solve the problems of poverty, food insecurity, and racism. And this is prevalent in our institutions of higher learning. As you can see, the author is a former dean, former associate dean at a Ivy League school of medicine. And, many of you, I empathize, because as you're listening to this and you're saying, well, Doc, I get it. Yep. I get it, why it's important. But have you seen my epic inbox? Have you seen my emails? Have you seen this, these value targets I have, these RVU targets that they keep sending me, they say I'm behind on? Do you see my tasks as an administrator piling up here, my papers and grants piling up? Certainly, burnout is a real thing. But I submit to you that one of the things that may even be more critical than burnout is moral injury. And moral injury, not being able to fulfill the things that we went into medicine or we went into gastroenterology to try to fix. And certainly I reflect on the Annals of Internal Medicine commentary. It's called, it was about a year and a half to 2 years ago, called Sir William Osler, Would He Have Made His RVUs? And that takes us back to where have we come from the art of medicine now to the business of medicine, and how is it impacting our morals? And I submit to you that this is our lane. I appreciate how this author of this commentary said, understanding the social drivers of health is not peripheral or tangential to health. It is key to diagnosing and meeting a patient's fundamental needs and restoring health. And certainly this takes me to an article published in JAMA that really was the impetus for the title of this lecture, The Moral Determinants of Health. This was published by Dr. Dawn Berwick, who some of you may know started the Institute for Healthcare Improvement in Boston. He also ran for office in Massachusetts as well while I was there during my Commonwealth Fund Fellowship. He says at the beginning of this, in any nation short of dictatorship, some form of moral compass, implicit or explicit, should be the basis of a just society. Without a common sense of what is right, groups fracture and fragments wander. Science and knowledge can guide action. They do not cause action. And so as we think about a moral determinants of health, these are the things, the values, the emotions, the values of that will be the foundations of our investments, of our work, of our policies, and the emotions we bring to work every day that make us effective, but also align with our values. Those things like love, compassion, mercy, kindness, human solidarity. Certainly there's, like I said earlier, there's been a clarion call for all of these things, and the urgency is for now. And how do we do that? How do we bring our moral determinants of health to the bench, the bedside, and the community? I submit to you that it's through proximity. And we get proximal to those populations that have been made vulnerable, those people who are at the margins, if we center at the margins. And we can do so by speaking, writing, working, voting, and most importantly, doing all those things by engaging with these populations. Now, let me set the record straight for a second. I want to distinguish community outreach from community engagement. These are two different things, but they often are used interchangeably. Certainly, we a lot of times and historically have patted ourselves on the back for community outreach, but what we really mean to be doing is community engagement. Community outreach is transactional. It's short term. I come in, I do a health fair, and I won't be back to this community for another year for the next year's health fair. Whereas what we need to be moving toward is community engagement. These are relational. This is where we build a relationship with the community partners and the community members, where we're accomplishing things together, where we are co-designing together. Some of you may still not get this. So let me put it in different terms that I hope you can appreciate. I have family and friends in New York. I appreciate going to New York as often as I can. And one of the reasons I do so is for the culinary scene. Okay, so I'm going to put some things in culinary terms for you. Some of you may remember this viral sensation Salt Bae. Okay, Chef Nusret Goseh. And this chef became viral because what he did was he would put the finishing salt on meat in a very unique way, bouncing the finishing salt off of his elbow onto the meat. This is like community engagement. We've already put everything together. We've planned the outreach. We've planned the health fair. We've planned to distribute education at this particular venue. Maybe we're going to a church and we're going to give a talk. We're putting the finishing salt on things. That's outreach. Whereas if we go to the French culinary term, mise en place, that's where we bring everything together before we serve. This is where we have the community at the table co-designing what we're going to do together, as opposed to doing something to the community or for the community. We're doing it with the community. So let me give you some examples, some real life examples of things we're doing here in Ohio that I've been engaged in that are examples of this. On the left, you'll see an architectural drawing of an old MLK library that became vacant that we as Ohio State acquired in January of 2019. What I appreciate about our approach that I was actively involved in was that we didn't say, oh, we just purchased this building, it's going to be a new ambulatory surgical center, or it's going to be a new clinic space. But we went to the community first and said, you know, this MLK library was a community hub. What do you want to see? How can we best serve you in this community through this space? And what we heard is, well, Doc, you know, this is the Near East Side of Columbus. We have some of the highest chronic disease rates. We want to help fix that. We want to move from being a repair shop focused to prevention focused. Okay, Doc, this is an area of food insecurity. We need access to fresh fruits and vegetables. And by the way, you know that there's no good restaurants over here. Matter of fact, there are no restaurants here. So a lot of times we actually go into OSU East Hospital to eat downstairs in the cafeteria to get a fresh meal. And Doc, we have no co-working space. So one of the things we designed, and we're in the process of constructing now, is this healthy community center where we have a teaching kitchen for families where they can learn how to prepare food to optimize nutritional value, and yes, on a budget, where we have a healthy retail cafe, where we have a fresh food market with one of our Mid-Ohio food banks to provide fresh fruit and produce for free. And we also have co-working space with meeting spaces as well. But this came about through amplifying the voices of those who have been marginalized. This also manifested after the first surge of COVID-19, because what I was hearing in the clinic and in the community was, Doc, look, I am glad, this was early May, Doc, I am glad that we are starting to reopen businesses here in Ohio. This impacts my livelihood, particularly as it impacts my family, being able to provide. But I'll tell you, Doc, I don't have the supplies, the hand sanitizers, the masks to re-enter the workforce safely. As a matter of fact, even if I did have it, it's hard for me to find right now. There's no hand sanitizer in any grocery store right now. And so that was an opportunity for us to leverage partnerships in the community and also with government agencies. We think about things like our public health agencies and working with even government officials. And so in partnering with some of our communities, even our larger businesses such as L Brands, which may be familiar with Bath and Body Works, we were able to secure hand soaps, hand sanitizers. We were able to secure masks through our facility. We were able to secure dental hygiene items from our dental practices. And in total, in 5 target zip codes, those same zip codes that I showed you early in the slide, those areas that were marked in blue and red with high social vulnerability, low resilience, high chronic disease, high burden of COVID-19, in those zip codes, we distributed 46,000 masks, 18,000 hand sanitizers, over 12,000 hand soaps and dental hygiene items to people who needed it most. And we published this experience, and this experience was leveraged by our governor to amplify it across Ohio. And I submit, whether you're a trainee, a faculty member, a staff member, your voice matters. Your voice matters. Whether you were advocating through ACG committee, whether you were advocating through your personal experience as a healthcare provider to your city council, to your state representatives, your voice matters. One of the things that I heard, again, amidst the COVID-19 pandemic, was that people were having, and these are people were going to work with COVID-19, knowing they had COVID-19 because they could not miss a paycheck. And so in talking with some of our city council, we were trying to find ways that we could provide funds for those people to safely recover at home. This became known as the Right to Recover program, and we were able to issue over $1.2 million to Columbus residents to safely recover at home. Your voice matters. Your voice can impact policy. But also, I return to something I mentioned earlier in regards to the digital divide. Yes, we were thrust into a telehealth revolution, but there were many people who were left behind. Those with low health literacy, limited English proficiency, low broadband capacity, or lacking the hardware. Certainly, we at Ohio State initially, January, February, before the pandemic hit us, there were 173 telehealth visits. But look at March to May. Between March and May, we had 100,000. But again, we were leaving folks behind. So how do we approach this? Again, and we shared some of this experience, disseminated some of this experience in a publication, but we all have to find ways to engage these populations who are likely to be left behind. Whether it is working on from a medical education standpoint and teaching our students and our residents and our staff and our faculty about having digital empathy and website manner, because it's much different to be face-to-face with the patient, be able to lay a hand on the shoulder to express empathy with a certain diagnosis or something that they are struggling with, than to do so through the screen. How are we accommodating those with disabilities? How are we accommodating those who have telehealth literacy challenges? Is there opportunity for us to leverage community health workers within our systems to help bridge those gaps? There's opportunity there if we engage around it. But also, I moved to Ohio. This was in August of 2014 when I started on faculty. The weekend before I started on faculty, that Saturday before that Monday, I participated in this African-American male wellness walk. It's led by Mr. John Gregory, as you'll see on the right. The African-American Male Wellness Agency has been around since 2004. It's grown to now, pre-pandemic, have approximately 30,000 participants per year, again, geared towards African-American health. And when I went to this fair, met Mr. John Gregory for the first time. He said, "Welcome to Ohio. I'm glad you're here. But look, I know you're passionate about colorectal cancer, but let me tell you what my community is most passionate about and what we need. What I'm hearing is people are dying prematurely of heart disease and diabetes. What can you do for me here?" And so this is the case that many of us who are engaged in community outreach as opposed to engagement are faced with challenges with, right? It's with how do you align priorities with your community partner? What if they come to you with something that is not your expertise, and how do you bridge that and foster sustainable relationships? Well, one of the things we found a unique opportunity because again, we wanted to bridge his interests and the need of the community around heart disease, around diabetes prevalence, but also one of the interests that I highlighted for you earlier is around colorectal cancer. And certainly the American Heart Association has a framework called Life Simple 7, in which they talk about ideal cardiovascular health. And that is also linked, yes, to heart disease, yes, to incidence of diabetes, but also to cancer, something I am interested in. And so I worked with a brilliant medical student. We did a systematic review to understand what has been done as far as community-based participatory research in addressing Life Simple 7, these metrics, whether it's obesity, nutrition, smoking, physical activity, and list goes on, 7 factors that influence ideal cardiovascular health, but also influence cancer. And what we learned through the systematic review is that number one, there was hardly anything that had been done amongst African Americans, almost zero that was tailored to African American males. And what had been done was of poor quality. So this led to us submitting a grant. And we got a grant to do a funded study that actually closed in December, where we walked 100 African American men with less than 4 ideal cardiovascular health metrics. We paired them with health coaches, community health workers that helped to navigate men not only to getting primary care, but to addressing social determinant of health barriers that they faced that would impede their health and well-being. But also, as many of you know, there's a lack of diversity in clinical trials. We also guided them to education, not only education about health and holistic health at that, from financial to physical to mental, but also educated them about the importance of clinical trials so that they could be champions in their communities and networks for increasing diversity in clinical trials. And we are working on analyzing this data now, should have some publications in the summertime. But also, if we are going to impact this, and I just talked about diversity, particularly the relevance in clinical trials, we also know that diversity and inclusion is important in our workplace, particularly as we look at the healthcare landscape. And one of the things that I was able to work with Adjoanne Yoboa, as well as Sophie Balzor and other members of ACG, was on this publication in regards to what we can do to improve diversity and inclusion in GI. And I strongly believe, and data supports, that we must create and support pathways at all stages of education. A lot of times we focus on those who are residents and who are declaring themselves as going into gastroenterology, but we have to start the pipeline much earlier. We need to include more holistic review in our application processes and certainly in our selection committees addressing implicit bias. We have to encourage mentorship and sponsorship for those populations that are underrepresented in medicine and cultivate a cadre of leadership that is diverse and inclusive. And I think about some of the activities and programs that I've had the pleasure of engaging in. This is just one feature of one program that I advise called Heads Up, which is really geared towards students who are immigrants, refugees, those from underserved areas within our school districts here in Columbus. And it's focused on introducing them to health careers because we strongly believe if you can't see it, you can't be it. If it's not, it's not publicized, you don't necessarily see a lot of African American or Hispanic Latinx physicians in the media, on TV, on billboards outside of your home. Just think about those billboards you might see in your borough as well. And so we wanted to make sure that it was visible so that they can achieve. And not only did we demonstrate that these children had a growing interest in health careers, but that their health literacy was also improving as a result of this. So we have to develop this pipeline. And certainly there is great, as Dr. Greenwald will tell you, there is great work happening through the Diversity, Equity, and Inclusion Committee of the ACG in regards to doing these things, whether it's assessing ourselves as a diverse body of ACG from our board down to our membership, assessing where the gaps are and where we can improve in being more diverse and inclusive. But pathway programs, whether it's our high school program, Prescription for Success, where we're starting this year to give scholarships to students as well, whether it's our medical school summer scholar program, whether it's educational programs that we're doing through our webinar series, postgraduate courses, ACG Universe, Diversity and GI Symposium coming up this year at the annual meeting, mentorship, or even sponsoring research. And we have a new Health Equity Research Award that's going to start this next cycle that's geared towards reducing disparities through a diverse and inclusive lens, or social engagement through our Diversity in GI campaign that has become international in amplifying the need for us to be more diverse and inclusive and celebrating achievements in this way. Also, you'll recognize some faces here. Dr. Pascal White, Dr. Ugo Uroku, who are part of a collective of physicians who started the Association of Black Gastroenterologists and Hepatologists. Another way to improve the pipeline, but also to improve the health of a specific population that has been marginalized, specific population that I highlighted for you earlier has been disproportionately impacted by colorectal cancer and other diseases. So to not only improve the health of that particular population, but to think of those within the community, those Black gastroenterologists, hepatologists, and scientists, and how can we promote, advance, build, network, sponsor, mentor this community to amplify them and to move us all closer towards health equity. And this is important for several reasons. Certainly within the clinic, we know that a diverse population of patient physicians, of physicians improves patient-physician communication, adherence to recommendations, and yes, there have been some studies that demonstrate that race concordance can contribute in some conditions to higher quality of care and better health outcomes. Now, before you start entering into the chat, I am not suggesting that every patient have a physician that looks like them. I am not suggesting that. I do not subscribe to that. Certainly, I subscribe more so that because people don't care how much you know until they know how much you care, they must find a physician, a healthcare provider who cares, a physician, a high quality, high value physician who believes in providing the best of care and is able to do so through their talent and their knowledge as well. But we also know that environments that are diverse and inclusive, our learning environments benefit from being more diverse. Students, residents, trainees have better problem-solving abilities, higher ratings for preparedness to care for patients, educational experience, and yes, we don't always like to tout ourselves around US News and World Report rankings, but it is associated with higher academic reputation. So we see the clear benefits of diversity and inclusion, even on patient outcomes. But as we look across the landscape, where's the diversity, right? This should be no mystery to you. If we look at Hispanics represent 6% of physicians, but a larger population is represented by 18% across the national population. African Americans, 5% of physicians, while we represent 13% of the US population. I can go on and on, whether it's persons living with disabilities, those who are LGBTQ+, and so on and so on. We have to be more diverse and inclusive, not only in our GI space, but in the healthcare space. And for a second, let me regress again and talk about African Americans. If I insert myself into this picture, I represent about 2.8% of physicians as a Black male academician. And like one of my colleagues suggested in a New England Journal of Medicine commentary, seeing a Black male physician, and I'll even narrow it, seeing a Black male gastroenterologist is almost like seeing a unicorn. But what can we do to change this, and how do we limit improving the current state around diversity and inclusion? Well, certainly we need to do a better job of recruiting from the pipeline, particularly as we think about historically Black colleges and universities, places like Howard University College of Medicine, places like Meharry, and so on. We must look internally. We must put the mirror on ourselves and do ensure that we are addressing and mitigating implicit bias into, particularly as it pertains to our interviewing and recruitment processes. So take for a second this gentleman on the right. This obviously was pre-COVID because he's shaking hands, right? And there's no masks. But let's take for a second this interviewer here, okay? This gentleman, this African-American male, he has freshly picked up his suit from the cleaners. You know, he's called his mom to make sure he didn't have any loose hairs on his face. His teeth were brushed. He's checked his breath, make sure everything is perfect for this interview. Has a firm handshake, and the interviewer says, okay, guy, I'm going to view this, you know, by the book. I have my checklist here. We're going to go by the credentials, these objective measures, personal essay. But what is this interviewer's unconscious mind telling him? He sees a Black face and associates it with danger, violence, misery, fear, and non-compliance. How do you think this will impact his assessment of this interviewee? We must address implicit bias. And certainly, we've learned over time now that we over-rely on things like MCAT and USMLE to tell us who's going to be a good physician. There's not great correlation there. So we must do more holistic review of our candidates. And our approaches to becoming more diverse and inclusive must be data and resource driven. And as we look at the pipeline, I want you to think about your pipeline. As you're thinking about those who come in as residents, go on to be fellows, early faculty, full professor, or even one day dean, chancellor, president. How many full professors do you know that are women, or Latinx women, or African-American women, or African-American men, or Latinx men? How many deans do you know that fit that description, or presidents or chancellors? We have work to do. And as we try to recruit this talent, we often fall short. And here is where we can change the trajectory. A lot of times we hire, but they are isolated. They don't feel as though they have a community that will support them and advance their personal mission and objectives to succeed. we tax them, right? There's a minority tax. Minority tax, oh yes, we understand that you're interested in addressing disparities. How about you also lead this diversity, equity, and inclusion work as well? Oh no, we're not necessarily giving you more FTE time to do it, but we presume that you're going to be excited about it, right? So you got some taxes there. Disparity in mentorship, how are we supporting them to, again, ensure that they're advancing towards promotion, they're getting committee spots, maybe it's like the ACG, for example, that they're being nominated for awards. There's an inequitable value proposition. If we look at promotion and tenure requirements, and you can look at yours, what value is placed on community-based participatory research? What value is placed on health disparities as it compares to maybe basic science research? We must reevaluate our value propositions. And certainly, I submit to you that we do so through a lens of anti-racism, and that requires that we transform the way we do education, the way we engage with our internal stakeholders, and yes, our external communities, but also that we revisit our policies and practices around what we do. And anti-racism is more than just saying I'm not a racist. It is actively working against racism. And certainly this is something that we feel should be a core value in our academic health system. And so we work to elevate this cause, to engage our internal and external stakeholders, and equip our team members to be able to do the work and to be anti-racist at our core. But without evaluation, we don't know where we're doing harm. We also don't know where we're doing good. So that is a critical part of what we do. And as mentioned in my introduction, I've been fortunate to be one of the architects of our anti-racism action plan that incorporates everybody from our chancellor, who's over our health system, our medical center, our cancer hospital, our health sciences, 8 health sciences colleges. But also it incorporates our employees, our students, our learners, our staff, our faculty into 9 action groups that cover things from education and training to policy and advocacy, to even things like resources and external partnerships. That's thinking about, well, who do we use as our suppliers? Are there any minority-owned businesses that we contract with for our suppliers? And if not, why not? What are we doing as far as data analytics and evaluation to evaluate our problem, to ensure that we are addressing these issues that have come about because maybe we've been discriminatory and maybe we didn't intend to, but we were. And certainly, what we've learned is also the importance of voting. And we've worked to integrate information about voting into our EPIC, we call it IHIS, with smart phrases where patients can get more information. We can send them things about voter registration, absentee ballots, voter reminders, as a part of the clinical encounter. It's important to amplify the voices of our patients, to amplify the needs that they have through voting. So I'm going to close momentarily to give some time for questions. But, I'll take it back to one of my earlier disclosures. I mentioned to you that I'm a father. I have 3 kids, Harper, who is 6, Ella, who's 4, and Noah, who just turned 2 last weekend. So story time is a cherished time for us. It's a cherished time for me because it's also a time that means that they're about to go to bed. And one of the books at Storytime that I enjoy, not them so much, but I enjoy, is What Do You Do with the Problem? And What Do You Do with the Problem chronicles the life of a young boy who one day recognizes he has a problem. This problem is pictured as a dark cloud. And he initially runs from it, he hides from it, he goes behind rocks to try to get away from this cloud. But the more he tries to avoid it, the larger that cloud becomes, until one day he decides he's going to face this dark cloud, this problem. And what does he recognize? He says, when he did so, my problem wasn't what I thought it was. I discovered it had something beautiful inside. My problem held an opportunity. I submit to you that we all face problems. We all face, our patients face problems, whether it's in our practices in regards to IBD, IBS, advanced endoscopy, liver transplantation, and hepatology, general gastroenterology, the list goes on. Our problems hold an opportunity. And what are we going to do with that opportunity? Certainly, as I've highlighted you today, we have an opportunity to bring our moral determinants of health to the bench, the bedside, and the community. Dr. Don Berwick closes his article and says, improving the social determinants of health will be brought at last to a boil only by the heat of the moral determinants of health. We must engage, speak, work, write, and vote. So I want you, similar to the beginning, again, if you're not driving, if you're not scoping, close your eyes. And I want you to think now. So I asked you earlier to reflect on a time when you actively participate in reducing disparities. I asked you to reflect on a time when you may have missed an opportunity. I want you now to think about a time and what you have in front of you, what you can do today in your workplace as you see patients, as you perform endoscopy, as you go back to your lab or computer to develop your next research grant. What can you do now? What are some strategies? What are some things you've learned that you can implement in the community, at the bench, the bedside, or even beyond that? You can open your eyes. And to our trainees, and yes, to even some of the faculty, let's zoom out for a second to the importance of knowing your why in doing this. And trainees, this is specifically for you. I want to give you a little bit of a lens into my journey, because as may have been painted, the picture may have been painted in the introduction, I've had some times of pivoting, whether it be going to 2 HBCUs for undergraduate and medical school, to then going to a predominantly white institution at Duke and WashU, where I did my residency and fellowship training. Also did some global health work in Bomet, Kenya while I was in residency. Did some patient navigation work locally in St. Louis during fellowship, and then recognized that there were some gaps in knowledge that I personally had that I thought would be beneficial to my patients and my community. So enrolled and got accepted to the Commonwealth Fund Fellowship in Minority Health Policy, where not only I gained some leadership skills around minority health policy, but also gained a really critical public health lens. And then started on faculty where I'm able to employ those skills on a daily basis, some of the work you've been able to see today. But the important thing, and I'll summarize it this way, it was summarized best by one of my Morehouse brothers, Sean King. He was presenting, he was the keynote speaker at a conference a couple hours away from where I am. It was in Akron, a Black Male Health Summit in Akron. And he gave the keynote. I was presenting one of the smaller sessions. But he said in his keynote something that it has taken me, minutes, 5 minutes or more to describe to mentees. He said it so succinctly. He said, do the thing that makes you come alive to impact the issue that breaks your heart. Do the thing that makes you come alive to impact the issue that breaks your heart. Health disparities break my heart. Social determinants of health that impede someone's health and well-being break my heart. And so I go at it with all I have and with all my passion, with all my heart. Same thing for you. Find that thing that you're most passionate about, that thing that breaks your heart, and try to fix it. I couldn't be fixing it. I couldn't be doing this work without a large team. And what I hope to be showing you here are many of my team members, from students to community members, to staff, to faculty, to researchers near and researchers far, collaborators across the nation. This is a team effort. This is team science. And this is the home team. I couldn't do it without them. So I had to give tribute to my wife, Brittany, of almost 11 years, my kids, Harper, Ella, and Noah. Thank you for your time.
Thank you so much for that very inspiring, powerful, impactful presentation, Dr. Gray. It's truly inspiring the work that you've done. And I particularly appreciate the comments you made about community engagement, about really including the community in their agenda as opposed to just bringing forth our own. I'd like to open this to comments and questions from our audience. I believe I saw Ari Greenspan's hand raised. Or not? Did Ari fall off? Okay, will I open it up to anyone else who has comments and questions?
It looks like Steve Iskowitz has his hand up.
Darrell, I've heard you speak so many times, but I have to say the way you put this talk together, going from sort of academic gastroenterology with your colon cancer research to the community, to your family, it was just amazing. I've never heard a talk like this before. And you have such a unique lens and a unique vantage point, being a Black man in academic medicine. Like you said, it's almost like a unicorn. So we're so privileged that not only did you speak to us today, but that you're engaged in the fight. I think your focus on the term I use when I think about anti-racism work is accountability. Accountability. Who as physicians are we accountable to? When you work in an academic structure, you always feel that you're accountable to your division chief or your department chair or your dean. And I feel like a lot of the decisions you wind up making is because you feel accountable to them. And the people we wind up being least accountable to is the community that we are there to help. And your point about community engagement as opposed to community outreach is so critical. And I give you a huge amount of credit for broadening your view of helping the community with respect to heart disease and hypertension, even though you're a gastroenterologist. So how do we as gastroenterologists really become accountable to our community? How do we engage the community? You know, you can go in and out of the community because you are viewed as one of them. And that's wonderful. How do particularly white physicians really, because most academic medical centers are physically situated next to impoverished tracts of land and impoverished communities. How do we as white physicians, if you can help us,
Yeah.
how do we navigate that?
Thanks for that question, Steve. I really appreciate it. What I would say is, it's so important that we be present. All too often, regardless of our race, ethnicity, we go into communities. I'll give you an example of a research study. We go in helicopter research, we do our study, and then we're gone. And what has been valuable for me, even though, it's interesting because even though I look like the community as a transplant, if you will, even from coming outside, moving to Columbus, Ohio, but also being a physician, I initially was viewed differently because it's almost viewed, you don't know my lived experience. You're a doctor, all right? But what helped me earlier was a few things. One is just being present. And I think regardless of your race, ethnicity, being present. And being present means not just being present when there's a health fair, when you're called to give a lecture, but if there's, some community event, whether it's through a church or a community organization, just having your face seen, it means a lot because people start to put the face with the name. So visibility, I think, matters, and being present, not just for your own needs, matters. I think too, one of the things, it's tough, and this goes back to accountability because a lot of times, and our current model of care, albeit we like to say we're going to value-based care, a lot of us are still fee-for-service, and fee-for-service means we're always looking at RVUs and return on investment. Well, one of the things I think we have to do a better job of is reevaluating return on mission. And so as we think about return on mission, that may require that we think about the time that we offer our providers to be able to do that work. One of the things I had the benefit of was as I came in as an assistant, when I first came in as an assistant professor close to 7 years ago, is I had FTE time to be able to build relationships, to build this kind of portfolio, to be able to start doing this work and research. And I think we have to invest in that. Again, this goes back to a piece of making intentional investments for the change we want to see. And that goes to accountability too. So I think being present, strategic investments, and I think just partnering because, a lot of community members and there's community facing organizations, they want doctors to help them. They want a doctor teammate, and that doctor teammate does not have to look like them. People are looking for that, whether it's a diabetes association, whether it's a colorectal cancer awareness group, they're looking for docs in their area to help them. And I think partnering is a key area.
Thank
Hey,
you.
Dave.
Darrell, that was like the most comprehensive, unbelievable discussion of that topic I've ever heard. And I agree with Steve, the way you weaved all that together is incredible. It's interesting that we've all focused so much on this community engagement versus community outreach. But I noticed that you're, in all your slides, you had engage, in red at the top, and it's really a call to action, which was incredible. You talked a lot about, zip code being more important than genetic code. And then, the value of relationships. And I love the way that you weaved compassion into the whole thing. So, more to a question, so how do we, it sort of goes to what Steve says, but how do we engage better? Like, how do we actually take this to an action? What's your top 3 things?
Yeah, I would say, one is, I think, I think at the heart of it is our education. So if I had to think from a GI division standpoint, one opportunity is to integrate this into a series of, I think about how we have our education structure here within our fellowship, within our GI division. We have like fellow presentations. We have different types of rounds outside of like a grand rounds like this, but integrate these themes into the education so that fellows and maybe residents who are on service with the fellows and the attending are getting exposed to this and see the value in it. So continue to talk about why diversity, equity, inclusion, and community engagement is important. It has to be integrated. It can't just be kind of one-offs. So that, I think that's a key thing. And then as much as possible, think about ways to include these themes in the patient encounters. So what might be an example of that? Maybe as opposed to a typical teaching rounds where you have your fellow, your med student, your resident, and the theme of the day is IBD. So we're going to talk about one specific aspect of IBD. We're going to have a lecture. We're going to have the student present on it. We're going to dissect it, pull out themes that the student missed and talk about that. But what if we have an equity patient rounds, right? Where we dissect for this patient, what was the social history for that patient? Okay, this patient lived in XYZ borough. And what do we know about that borough? What do we know about this address or area within that borough in which this patient lives? Where are the grocery stores at? How can this impact this patient's health? We see this patient's been readmitted 3 times for the same thing. They no-show to their clinic, but are they no-showing because they got to find, 3 trains and a bus to get to the clinic? Are they no-showing because of limited access of some other reason? So I think there's opportunity to integrate this into our education so it's top of mind all the time.
Love that. Darrell, you're amazing. Thank you.
Thanks, Dave.
Really great.
No, it's
absolutely, really inspirational talk. Thank you.
Thank you very much. Thank you. Well, I appreciate you guys so much. Thank you so much. I appreciate that kind introduction, Dr. David. Thank you so much as well.
Thank you so much for accepting our invitation. This was really a wonderful grand rounds. Sorry that you can't be here so we can chat more in person, but
yeah.
Until next time.
Absolutely.
We'll get Darrell to New York.
Thank you.
Definitely.
You all be well.
All right, Darrell. Thanks so much.
Thank you.
Thanks so much. Stay well.